The objectives of this presentation is to review two different case studies that differ for the patient's pathology and what sedative we could be giving them, examining the risks and benefits to each clinical situation. So the first case study consists of you were called to a 66-year-old male patient confused and experiencing hallucinations. You arrive and the patient's partner states Bruce stopped drinking a day ago. He usually drank 14 to 24 beers a day for the past 20 years. For the past 12 hours, he has had nausea, he's had vomiting, chills, and body aches. Bruce is mumbling to himself and will only answer certain questions. He is quite diaphoretic and he states he's seeing large spiders crawl up the wall. He starts retching and vomiting out liquid. No blood though. Bruce can only answer your questions with incomprehensible sounds, and he seems visibly frustrated when he tries to speak. He's around GCS 12. When you take his vital signs, you see his heart rate's 140 strong and regular, his respiratory rate's 24 breaths a minute, regular and shallow, his oxygen saturation's around 97%, and his blood pressure's 170 on 92. So overall, you can see he's pretty sympathetically driven. He's had this huge surge of catecholamines leading to all this hypertension, tachycardia. When you take his blood glucose, it's 5.8, so he's not hypoglycemic, and as well, his temperature is reading 38.9, so he's febrile. So when you state you need to take him to the hospital, he starts threatening you and spitting on you. You attempt de-escalation methods with no success. You have to call the police and wait outside the room until they arrive. So what is this patient experiencing, and what sedative would be beneficial for this patient? So let's examine this. So there's so many different reasons and causes of agitation in the pre-hospital setting and the in-hospital setting too. The overarching theme is if the patients have a reversible cause, it obviously makes sense to customize a treatment plan to rectify the reversible cause. To highlight, if patients are hypoglycemic, it of course makes sense to administer D10 or D50 or glucagon to improve their blood sugar and minimize their symptoms. Comparatively, if patients are hypoxic, it obviously makes sense to give them supplemental oxygen to rectify their underlying dysfunctional disorder. However, we know that may not be practical in the pre-hospital setting depending on so many different factors. Also, patients could be experiencing alcohol withdrawal. And this is what the patient in the first case study was experiencing, which is a pretty significant disorder. Patients could be using drugs like cocaine, methamphetamine, ecstasy, or E, and this could obviously all lead to an increased agitation combativeness, which jeopardizes our safety and everyone's safety that's involved. Overall, patients could have so many different mixtures of drugs or alcohol or underlying conditions that could lead to combativeness and agitation, and it's paramount to kind of understand and establish what's the cause or causes, and so we can develop a treatment plan for that. Finally, patients are obviously experiencing psychiatric exacerbations. What if they're not taking their medications as prescribed? Or what if it's their first episode of an underlying and undiagnosed condition? That could obviously increase the risk of agitation and combativeness. But if we look at alcohol withdrawal, this patient was experiencing it. So this is a pretty significant disorder. There's a spectrum of clinical severity and as well as clinical manifestations. Because usually if you look at like the textbook answer, when you have this abrupt cessation of utilizing alcohol, 6 to 12 hours, you start manifesting symptoms. And in hospital environment, they actually assess patients on a scale to see how severe their symptoms are, because a treatment plan needs to be established to prevent seizures, to mitigate symptoms, and mitigate morbidity, because it's a pretty dramatic and pretty severe clinical circumstance. So overall, when you utilize alcohol, especially 14 to 24 beers a day for 20 years, you develop significant tolerance and dependence on that. Tolerance means you need to increase the amount of alcohol to achieve the same desired effects, right? And obviously, if you are abruptly stopping your alcohol use and you go through withdrawal symptoms, your body is physiologically dependent on that. So that's why you're manifesting these symptoms. But overall, the worst kind of situation that alcohol withdrawal can lead to is the CNS hyperexcitability and dysfunction. And what happens when you use alcohol, especially for long-term use, this increases the amount of glutamate. So glutamate is increased, which is our main excitatory neurotransmitter in our CNS, which binds to NMDA receptors, and this leads to excitation. And that means our postsynaptic neurons are going through depolarizations, so they subsequently have action potentials. Comparatively, GABA receptors is reduced because alcohol is a potent GABA agonist. So if alcohol binds to the GABA receptors, obviously over time the GABA receptors are going to downregulate, and you're going to have a reduction in GABA, which reduces the chance of action potential and reduces the postsynaptic neuron from being depolarized. So it has this opposite effect. So now you're going to get this unrelenting gas, and you get less breaks. So you can see what happens. And kind of the main troublesome symptom of alcohol withdrawal is hallucinations. And the reason for that is this large surge of dopamine that goes through patients when they're going through withdrawal, and this can lead to the hallucinations. And as well as dopamine is a pretty pivotal neurotransmitter, and it's involved in motivation and reward. And obviously, if we do well on the tests or win a big sporting event or just through certain drugs, we get this large surge of dopamine, and this reinforces the behavior. But when it gets too high, especially in withdrawal situations, this can lead to hallucinations. And to apply it to our case study, the patient was seeing spiders go up the wall. So obviously hallucinating, and this is pretty significant clinical manifestation. As well, usually after 24 hours, depending on the patient and the textbook, they can develop DTs or delirium tremens. And this is the reason because patients have this large surge of sympathetic nervous system activation. And when you get all these catecholamines released, such as epi and norepi, you increase your heart rate, you become hypertensive, you become pale, cool, diaphoretic, and overall it can lead to the shakes. And you get mydriasis, which is our pupils dilate, and this can obviously lead to all the symptoms that the patient was experiencing. So his heart rate was 140, blood pressure was 170 on 92, pale, cool, diaphoretic. So obviously pretty sympathetically innervated. So that's why he's manifesting those symptoms. But we know ethanol is a main component of alcohol. And overall, alcohol is a CNS depressant because, again, it binds to GABA. And if it's constantly binding to GABA over chronic use, that's obviously going to down-regulate our GABA receptors and our sensitivity to it. So that's why you get this reduction in GABA, which is our main inhibitory neuron. However, alcohol also acts on NMDA receptors. So now you get this large production of NMDA receptors, so you have more receptors that the excitatory neurotransmitter glutamate can bind to. So when patients go through alcohol withdrawal, now you have this enormous amounts of NMDA receptors and large production of glutamate. Glutamate binds to the NMDA receptors. That can lead to this unopposed excitatory state that leads to the CNS dysfunction. Inversely, if you have this downregulation of GABA receptors to act as the brake, you don't have sufficient amounts of GABA to kind of prevent that excitation from happening and the CNS dysfunction. So this is literally what happens when you abruptly stop alcohol withdrawal if you develop a dependence on it. And the tolerance happens because overall, if you chronically use alcohol, this would downregulate your receptors and sensitivity, and thus you would need more alcohol to bind to those receptors to stimulate a physiological effect. That's how the tolerance actually develops, which is really interesting. However, if you look at all the empirical evidence, benzodiazepines have very strong and rigorous evidence to give for alcohol withdrawal. So agitation, anxiety are main symptoms of alcohol withdrawal in this patient's experiencing this, and obviously our de-escalation methods have failed, and this can lead to so many different benefits. So we can prevent seizures because midazolam is anticonvulsant. We can prevent harm and ensure our safety by decreasing the amount of excitation and agitation and combative behavior by working on different areas of the brain. So midazolam, quite briefly, we'll review more in another video, binds to the GABA receptors. And there's two different subtypes, GABA A and GABA B. Primarily, they bind to GABA A, and this leads to the influx of chloride. So midazolam binds to GABA, but more chloride's going into the cell. That means it's more negative, and this leads to hyperpolarization, which means it leads to inhibition. So less likely for postsynaptic neuron to create an action potential and depolarize. So that's why, again, when it does that, it can be an anticonvulsant, anxiolytic. It can cause sedation and calmness and works on different areas of the brain. And overall, it provides a very comprehensive treatment plan for these patients going through withdrawal. So that's why it's the preferred sedative agent for this patient going through alcohol withdrawal. We will compare ketamine for a different case study and what are the risks and benefits for giving it there.